Hello, everyone. My name is Laura Beck, and I am a part of the home office of the Eden Alternative. I am delighted to be here with you today again for the second part of Trauma-Informed Care, Making Peace with the Past, featuring the work of Lisa Kendall. So there's a couple of things, kind of like we did last time, that we need to cover before we get into the content today. It's a little bit about how to use the Zoom system appropriately for one of our feature webinars. There are a lot of you on the line, and we really want to make sure this goes well for everyone. And even more importantly, you all get a recording link as part of what you pay for. And so we want to make sure that the recording is tip-top quality for all of you to use for the whole year that you have to use that recording link after today's date. So pretty cool. You did receive in your email from our registration system a link for last week's recording. So again, make sure the person who registered for your team is checking not only their inbox, but their clutter or their spam to make sure that that email was picked up and that that link is preserved for the year that you have to use it. So you don't want to miss out on that. Very important. Couple things before we move on. I have you all muted against your will. That's, for your benefit, so that again, your experience can be the best possible quality and that we can spend our time listening to Lisa. But the other thing I need to ask you to do is to look up in the upper right-hand corner of your screen. You have a choice between something called Gallery View, which looks a lot like Hollywood Squares, or Speaker View, which will put the person who is speaking up on the screen, and it will be a whole lot less distracting considering the nature of today's presentation. So I highly, highly recommend that you choose Speaker View. There will be some slides, but there won't be slides the whole time. And so when there are people speaking, it will feature the person speaking, and I think you'll like that a lot better. Also, please make sure that you do not share your screen at any point in time. You will be disrupting what's visible to everybody else, and we don't want that to happen. So we want to keep our focus on the content that Lisa has prepared for you today, and so we love the teamwork that you can help us create here and make it a really great experience for everyone involved. So you're going to do something kind of cool today that you didn't do last week, because today's session, there are more opportunities to interact and work together in small groups. And you're probably wondering, well, how do I do that on a system like this? So Zoom has something called breakout rooms, and I've separated all of you into 12 breakout rooms. And so when Lisa asks you to consider a specific question, I am going to hit a button that breaks you into smaller Zoom rooms, if you will. So you're going to be in there with other organizations and other people who were registered for this webinar. When I hit go on those breakout rooms, please accept the invitation to go into the breakout room. And then just join in, and somebody who's brave maybe can start the conversation and enjoy getting to know people's stories and their perspectives on the question that's being posed. It's a really cool way to learn from each other and not just learn from Lisa. And that way she can also learn from you when you come out of your breakout room. So just be prepared for that experience. We think you'll like it. Last but not least, CEU is very important. I know that's something you really want to know about. It's going to work just like it did last time. Please stay until the very, very end of the webinar today so that you can receive the information you need to apply for the CEUs for today's session. It will require you to stay until the end, and there's information that will only be shared then. So please make sure that you take advantage of that opportunity if the CEUs are important to you. And so with that, it's time for me to reintroduce Lisa. And for those of you who weren't here last week, I'm going to go ahead and share her bio again. So Lisa Kendall is a social work psychotherapist and a clinical gerontologist. She is passionate about supporting the well-being for elders and their care partners, and has been so for over 35 years in a variety of care settings. She is formerly the Senior Consultant for Work and Family Services at Cornell University in Ithaca, New York, and now serving on the President's Advisory Council for Work and Family Affairs. Lisa maintains a private counseling and consulting practice in Ithaca, New York, as an educator and mentor for the Eden Alternative, and teaches the nationally recognized fieldwork course for the Ithaca College Gerontology Institute. She is a founding member of the Finger Lakes Trauma Informed Network in upstate New York. Lisa speaks to international audiences about the importance of person-directed, trauma-informed elder care. And you can read her blog on self-care for all members of the Care Partner team at www.lisakendallcounseling.com/blog. I'll make sure I get that into the chat box at some point in time. All right. One last thing. I did make sure that the people who are registered in the system today received an email with the handouts for today's session. Hopefully you received that and were able to download them, but fear not, I am also going to pop that link into the chat box for your use. And so with that, Lisa, please, it's all yours.
Okay, thank you. Yeah, I was getting a message that that I was powerless there. So thank you so much and welcome everybody. It's really great to be back with you. And I want to start out by just checking in with everyone, taking a moment to notice the transition between whatever's been happening in your busy day and the time that we've set aside. And to thank you for taking the time to be with us here and maybe just pausing to take a breath and acknowledge that this is a little time for education, for sharing, for both giving and receiving care for each other. In the Eden Alternative, we define care as anyone or anything that helps another to grow, and that's exactly why we're all here today. Over the past week, we asked everyone to take a look at some growth work. You had the option, and hopefully you had an opportunity to do all three. You were invited to take a look at a TED Talk by Dr. Nadine Burke-Harris about trauma and trauma-informed care. You were invited to take the ACE questionnaire, and if you felt able to do that, to share your score with your teammates. And if you didn't feel comfortable to do that, to talk about what was coming up for you in that moment. And you also were encouraged to take a look at some, now I'm blanking on what my third thing was, maybe you guys could share that with me. But your growth work was important for you to do over the course of the last week. And what I'd like to do now is to invite you to take 4 minutes in your small groups to share what your aha moments were for you in looking at your growth work over the last week. And so, Laura, if we could just have folks go into those small groups now, the group breakout sessions for about 4 minutes so that folks can talk about their aha moments over the last week, and then we'll come back together.
That sounds great, Lisa. And just a quick reminder, all of you are going to get a little box on your screen asking you to accept your invitation to the breakout room. Please make sure you do that and just have some fun having a conversation. Some people have asked me if the chat box is activated in each breakout room, and that is a yes. So if you don't have audio today, I will make sure that you can do that. I'm going to unmute all of you right now as you go into the breakout rooms. So if you can just be really quiet in the background while I get you into those breakout rooms.
I want to take a moment to thank you all for taking some time to cover what you did with your growth work. It's so important. We did cover a lot of material last week, and I want to acknowledge that there were a lot of things to look at in the growth work. And if you didn't have a chance to do everything, that material is there for you to look at in the future. You don't have to do it all at once, but do take some time to go through it and to look at it in the coming weeks. What we'll be doing in our time together today is a quick review of what trauma-informed care is and why we're looking at it now, and then spend the rest of our time really looking at how we start to implement trauma-informed care in our organizations. I have some evidence-based screening and assessment tools to share with you. You will be getting these in your handouts, and I'm also going to show you how to find even more information online. We'll take some time with beginning that process of action planning and give you some tools for that. We will have some conversations about how to anticipate barriers as well as look at opportunities as we do action planning with our teams, and again, give you lots of resources and put tools right in your hands so that you can move forward with making sure that your organization is moving towards being as trauma aware and trauma responsive as possible. So we'll be taking a quick look at these definitions as we looked at last week, taking a look at what trauma is, not forgetting that growth can come from trauma and how resilient human beings are, and also looking at what trauma-informed care is. So this is our quick review. The definition of trauma that we use does come from SAMHSA. That's the Substance Abuse and Mental Health Services Administration. It's a governmental organization that has so many great resources for you that I hope you will use them as a resource. They define trauma as the state of mind, really, and this physical state as well, that results from an event or a series of events or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has a lasting adverse effect or impact on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. We like this definition because it is broad, it is person-directed, it's defined by the person, and we see how it affects functioning and well-being. And it's not just a mental state, it also has to do with the physical state. And if you did have an opportunity to think about the Adverse Childhood Experiences Questionnaire or listen to Dr. Nadine Burke Harris's TED Talk, you have a really deep understanding of how even emotional trauma has an impact on our physical health and well-being. And if you're working in a healthcare setting of any kind, you have an understanding that a lot of folks that we encounter every day, people that we serve, as well as people in our own families and coworkers, and even in our own lives, how we might be dealing with the physical consequences of emotional trauma. Again, we don't want to let go of that idea of trauma resilience and the idea that growth happens after trauma. And that was the third thing that I hope you had a chance to talk about, because it is so important. Noticing stories of trauma growth around us, noticing ways that people might have grown as a result of the bad things that have happened to them, and the ways that people not just survive, but actually thrive directly because of some of the things that have happened to them. We know that trauma-informed care is about organizations and how they structure themselves and how they work within a framework of treatment that involves understanding, recognizing, and responding to the effects of all types of trauma, and also emphasize physical, psychological, and emotional safety, not just for the people that we serve, in this definition referred to as consumers, but also for providers. That means the care partners that work in your organization and the family members, and helps survivors rebuild a sense of control and empowerment. So that is the definition for trauma-informed care. It's about an organizational framework wherein people are recognizing trauma and treating it and creating a safe environment where people are not re-traumatized and that treatment is available. Here's a quote from Ernest Hemingway that I really like, and it says, "The world breaks everyone, and afterward, many are strong at the broken places." And I don't know if you recognize this piece of pottery. I have, there's a little crack in this pottery, and it's filled with gold. And this particular kind of pottery is called kintsugi. It's a Japanese word, and it means a kind of pottery that once it's broken, it's repaired with gold. And the idea is not to hide that there has been a break there or that there's been damage. In the Japanese culture, they recognize that things break and that that doesn't destroy the value. In fact, where people have been broken or where harm has come to them, the repairing of that wound can actually make people stronger, and that we don't want to hide that damage. We want to actually celebrate the things that have happened to us. We can think about that as a parallel with aging. And in our culture, the Western culture, we look at the wrinkles we get or the gray hair we get, the wear and tear that happens to our bodies as a bad thing, something we want to hide. But why are we not celebrating fact that we've lived many years and that we are survivors of life. And so I really like the idea that this kind of uh, wear and tear on pottery is actually celebrated. It's highlighted in the Japanese culture. So kintsugi is a special form of art that I especially love. And it reminds me of a story of someone that, and I'm going to stop sharing just for a moment so I can look right at you here. Um, it's a special story from very early in my experience, my very first experience working directly with elders. It goes all the way back to the early 1980s when nursing homes were helping to support people who were being discharged en masse from large state hospital systems. The state hospital systems in New York and Pennsylvania were where people had been housed, sometimes for decades, in mental hospitals. And our nursing home, where I was working as the social services director, was helping to take in, we were screening and bringing in people who were appropriate to live in nursing homes. And there was a woman named Claire, excuse me, who came to live in our home after living a lifetime in a state mental hospital. And we learned about her story. We learned that when she was 6 years old, her mother had committed suicide, and her father, who had been physically abusive and who lived with alcoholism, was not able to take care of her, and she had been taken away and had been placed in what was then, and this must have been at that time, turn of the last century, um, a home for feeble-minded children. That's what they called them then. And after that, she just grew up institutionalized. She lived in the state hospital until she came to live in our home. And Claire came walking up to me one day, very soon after she was admitted to our nursing home. And she just looked me right in the eye and she said, "I want to thank you because I deserve this." And she was so grateful for having been brought to live with us in our nursing home. And I was so stunned by what Claire told me that day, and realizing that she had lived her whole life in a mental hospital and before that had been taken to a home for feeble-minded children. And even in 1983, we recognized that the chances that Claire was actually, living with some kind of developmental disability were questionable, that it was a place to house children that no one knew what to do with, um, or that she actually even lived with a mental health challenge. She was just institutionalized. And what she taught me, and she's one of my great wise elders in my career. I think of her all the time. And look how many years it's been since I met Claire and she came to our home, and she thanked me for bringing her to live with us. And she felt that she deserved that. And I thought, my gosh, um, this is real resilience. This is a spirit that never was extinguished, never was crushed. And I just want to share Claire's story and extend her teaching to you across these generations and decades, and share that story of resilience. And I'd also like to invite you again to go into your breakout groups, and if just one or two of you in the time that we have available have a similar story from your work or even from your personal life about that kind of resilience, I'd love for you to share that now, and I'll invite Laura to help us get back into our breakout groups. We'll be in the same groups we were in before. And again, take about 4 minutes to share stories that speak to that resilience or trauma growth. Um, I would love for us to do that. So let's take 4 minutes and go back into our groups. And just one or two of you, and you may not even realize that those were stories that connected with trauma, but let's just share those if you have a story. Thanks. Thank you, Laura. I certainly heard some wonderful comments in my small breakout group, and I wonder if just one or two people would like to either speak up or put something in the chat box as highlights or headlines from their stories. Was there an especially powerful story that somebody wants to share with the larger group?
Lisa, what I would like to ask, if somebody wants to be unmuted, if you would raise your hand. There's a little hand raise icon. Um, in your system. Either that or jot some things down in the chat box. So I'm going to look here to see if there's someone who wishes to be unmuted because I have everyone muted.
That's the best way. Thank you.
And I don't see any hands going up.
Yeah. If I could just say I mean, there's some very poignant stories, but one point that was made in our group is that with the work that we do, we all hear these stories all the time, and that this idea of resilience really isn't new to us, that we hear stories about people who've lost children, who've served in war, who've lost spouses, who have really been tremendous survivors across the course of their lifetimes. And we are the recipients of those stories. If we're working in healthcare, if we're working in home care, if we're working in assisted living or in nursing homes, these are the stories that we're hearing all the time, and we're the recipients of those, what I feel are sacred stories that people entrust to us. So that's, I think, is a really important point to share. So let's go ahead and, I see a note from Meredith Martin that Mary had a great story of resiliency. Can we unmute Mary and get that story?
I would love to, and I will do that right now because fortunately we have just one Mary in the list.
Well, that's lucky.
Hi. Can everyone hear me?
I can hear you, Mary.
Okay. So what happened to me about a year and a half ago, I got a really severe strep A infection in my blood, and I ended up in ICU for 9 days, and I was on a ventilator for 4 days because I was going into respiratory distress. And I remember at the time thinking, should I be saying goodbye to my husband? Am I going to wake up? They thought I had flesh-eating disease in my foot, and I didn't know if I'd wake up with no foot. And I had like 12 IVs going, and it was just a horrendous experience. And I was on IV antibiotics at home. So it took me 7 months to recover physically. And then I was trying to decide, now what do I do with my life? Where do I work? And I got this absolutely wonderful opportunity to go and work in the Cayman Islands for 3 months in palliative care. And I took it, and I was so proud of myself because I had just recovered from, a near-death experience. I had to go there and learn to drive on the other side of the road, learn the whole island. I didn't know anybody there. I went all by myself, and I had the most wonderful experience. I was right by the water. There were days I actually felt 100%, and I had so much emotional healing that I was able to accomplish being there. And it was such a wonderful outcome from the trauma I had been through.
That's wonderful, Mary. We're glad you're so much better and that you had that opportunity to heal. Thanks for sharing. Appreciate
You're
that.
welcome.
I hope I didn't put you on the spot.
No, that's fine.
Yeah. Thanks so much. Thanks everybody for sharing your stories and sharing from the wisdom of your own practice. Let's get back in here and take a little time to talk about why we are talking about it in this way. Trauma-informed care really is culture change. So if you have been on that journey, trauma-informed care is person-directed care. It is strengths-based care. It is best practices, and it is another step in your culture change journey. It's not something separate. And so it's something that we need to be doing, whether or not it is mandated if you're part of a nursing home setting by the Centers for Medicare and Medicaid Services, which it also is, by the way. So that trauma-informed approach, again, is something that realizes how widespread the impact of trauma is and also understands potential paths for recovery. It is something that learns how to recognize signs and symptoms of trauma, unresolved trauma, in clients, families, staff, and anyone who connects with the system. And it responds by having fully integrated knowledge about trauma into policies and procedures and practices. And it's a system that is working very hard to avoid re-traumatizing people that are intersecting with the system. And we talked a little bit about that in our conversation last week. We don't want people who are coming into our agencies, our organizations, or our homes to be re-traumatized uh, by that encounter, or who are receiving care from us to be re-traumatized, or who are working for us to be re-traumatized. And so that's why it's a systems-wide approach. The key principles of trauma-informed care include, and this is a recapitulation of last week's conversation, organizational safety, being trustworthy and transparent, being sensitive to cultural differences, collaboration between staff, people who are receiving care, the organization, families, between those folks and among those folks. And empowerment. And again, if you're part of the culture change movement, you know that this is a core principle. And so all care partners are collaborating and being sensitive and trustworthy and transparent and being safe with each other. And so you can see that this is very much the same idea as any other culture change movement. Again, we're making that shift away from what's wrong with you to tell me what's happened to you. And we're recognizing and accepting what we normally would think of as symptoms or behaviors as strategies that have been developed to cope with trauma, not just in childhood, but actually anywhere across the lifespan. So we spoke about the regulations that the Center for Medicare and Medicaid Services has developed as phase 3 of the regulatory changes that have been rolling out over the last few years. And phase 3 is what's coming into play in November of this year. And I've just very quickly summarized for you what is involved in phase 3. And it has to do with care planning, quality of care issues, specifically around trauma-informed care, and making sure that all nursing staff is competent to address these trauma-informed issues, behavioral health services, and training. And I've listed on the next few slides for you the F tags, and this information is specifically for nursing homes, so that you'll have them in your notes when you get the slide handouts. But I wanted to take you really briefly to the CMS webpage so that you can see, if you haven't looked there yet, everything that's available for you on that webpage. So I'm gonna get into that website right now for you, just really quickly. Let's get into the screen here. Oops, okay, that wasn't it. Sorry, my screen is not quite big enough to see. There we go. Nope, it's not working. Oh, I'm sorry. I practice this a lot, and it's just not helping me here. I wanted to show you the CMS website, so. There we go. And everybody see cms.gov. Laura, can you nod at me if you can see that? Yes, yay, okay. This is a website, and in your handouts you have the link directly to this, as well as the links that are all listed under here. This is the cms.gov website, and it's specific to nursing homes, but I want to just show you all of the information that we're talking about is available about the phase 3 changes that are coming out for you. And this is the the requirements for participation. And you'll see here, they have slide programs, they have information here about what the surveyors will be looking for when they come to do your surveys. They have information, the appendix PP State Operations Manual is listed here. They have FAQs. They have an FTAG crosswalk here that'll show you everything you need to know. The final rule, the code of federal regulations, all of the documents are listed on this page. And I just wanted you to be able to see this because it is where everything that you could be interested in looking for in terms of the regulations is available on this page. So I wanted that to be available for you there. And Laura, can you see now my slides? Are we back on the slides? No. Okay. Let me do this.
Just make sure that you stop share before. There you go. You're perfect.
Ta-da! Okay. Thank you, guys. Thanks for your patience. So just to quickly review those F tags for the nursing home folks, and this will go really quickly for those of you who are not on the nursing homes. The comprehensive resident-centered care plans do have to be done by qualified persons, and they have to be culturally competent and trauma-informed, and that's an F tag. That's how important it is to CMS. That's F tag F659. Quality of care also includes that it is trauma-informed care, F699, and that the nursing staff is competent to address trauma-informed care under quality of care. Behavioral health services have to be sufficient and competent staff to meet behavioral health needs, and that includes certification and licensure as needed. And again, they address the competency of nursing staff to meet this need in behavioral health services. And the training requirements also cover all of the preceding items. So the training requirements cover trauma-informed care as well. So these are issues that CMS is going to be looking at they actually have started for some of these items, but the phase 3 starts in November. I believe it's November 28th of 2019. And so the question for us is really, where do we start? And so I wanted to bring some hands-on documents, worksheets, checklists, things that you and your team can start to use right away to help you get started with getting ready for phase 3. And if you're not a nursing home, these are still for you, because every organization, even if you're not a healthcare organization, I mentioned earlier in our small group, I teach for the Ithaca College Gerontology Institute, and I had to do a workplace violence workshop as part of my employment there. And I just did that this week, and it was all about trauma-informed care. And I thought of all the examples they gave and how they would fit in with this conversation. Any business, any organization needs to be paying attention to these issues. So if you're here on this call, you are walking along this same path. So these documents will be helpful for you. And one of the biggest resources for you, again, will be SAMHSA. That's the Substance Abuse and Mental Health Services Administration. They have, now it says store, but virtually everything in their store is free for electronic download. And if you want to order any of their booklets to have sent to you, I think you have to pay for postage, although a lot of their stuff is not in stock. The Tip 57 book is Trauma-Informed Care in Behavioral Services. It's a tremendous resource. It's a thick book. You can just download it online. And they also, and the Tip 57 is all about trauma-informed care. They have smaller booklets that summarize the information, and then even smaller pamphlets that are clinical pamphlets that help people with things like screening instruments and so on. And then Tip 59 book is all about cultural competence, and that's tremendously helpful. It gives case studies and other information. And they've got a whole series of these books depending on what you're looking for. And you have references and links to these in your handouts. So I want to start by showing you some assessment tools for your organization. Also assessment tools that will help you assess quality of life and potential screening for trauma, for burnout, and for compassion fatigue for your staff, and also screening tools that you can use for your residents or for your clients, depending on the kind of organization that you have. So I'm going to do the magic thing with stopping sharing again. And well, let me actually do this first. Let me go through the slides quickly just to show you what we're going to be covering here. There are organizational self-assessment tools and resources, and let me start there just by talking about what it means to do an organizational self-assessment. This is a survey that you can really do of your organization that would take you virtually from the front door all the way through your policies and procedures. And let me show you what's available in that realm. So let's open this up. One of the tools that I've included for you is something, and this is in your handout, so you have it. You don't even have to look it up, but you do have the ability to look this up through your handouts. This is something that was developed by the Center for Health Strategies. It's called Laying the Groundwork for Trauma-Informed Care. It's a brief that has information about how your team can start to get together and what you need to consider when you're doing this kind of work. So you'll see on the handout here how you start to build awareness, how you generate buy-in for a trauma-informed approach. One thing you need to consider, for example, is promoting the potential to improve patient outcomes as well as staff wellness, how you incorporate patient voice and choice early on, how important it is to offer trainings for all staff, identify early champions or natural leaders to help build awareness, how you identify opportunities to sustain upfront investments. So those of you, again, who've been involved with culture change, you know how to do this. You're way ahead of the game because you've done this already by introducing person-directed care into your organization. This is one of the handouts that's in your packet. Here's another one. It's from SAMHSA, and it's in your packet. Let me show you what's available on this one. I must have scrolled down earlier, so I'm halfway through. This is an organizational self-assessment that is designed to help you improve your policies, procedures, and practice and your physical environment so that you'll be more in line with trauma-informed care. And it's actually a checklist, so you can use, your team can use this as a way to evaluate. So you'll see it has specific questions. What does your screening and your comprehensive assessment of trauma look like? And then you give yourself a grade. This looks like it's geared towards primary health care, but you can use this in any environment. Just adapt the words a little bit. You and your team will be able to do this easily. What's your system to complete a comprehensive trauma assessment, and so on. And then you have places to put in extra comments. So this kind of tool is easily adapted. Here's a document also from SAMHSA that talks about what the steps are to create a vision for how you want your organization to look and feel. I'm going to back up again here. This is your implementation planning guide. Make sure you have leadership buy-in. That's the 10th principle in the Eden alternative philosophy, right? Wise leadership is the lifeblood of any organization. Ensure that your leadership has bought in. We need that. It's the 10th principle, but we need that first. Consider the makeup of your core implementation team. Plan your meetings. So this can help you lay it out when you go back home and when you go back to your team after the webinar. All you need to do is make sure that you print these out and you can sit down with your team and start to work right here. So I wanted to make sure to share these with you. Let's go back to our other items that we have. So that is what's available to you in the packet, in the handout about organizational self-assessment. It's really key that you start there. So this is what's available, the implementation planning guide, organizational self-assessment. There's also a scoring tool there for you. And then the trauma-informed care scoring tool and graphing guide. These are all available at the SAMHSA website. other resources that are similar to these that are also available, and these links are live for you to work. The ACEs Connection website, the National Council for Behavioral Health is a resource. The Trauma Informed Care Project, where we get our definition for trauma informed care, has resources. And the Traumatic Stress Institute has resources as well. And I just want to remind organizations that are part of the Eden registry, you also want to look and start with your warmth surveys. This is a great way to take the temperature of your organization and find out how responsive you are to the needs of the individuals who work there and who live there. This is, again, you're way ahead of other organizations in trying to figure out how trauma responsive you are likely to be.
Lisa, can I just
Yeah.
pop in one moment on that?
Yes.
The good news is that the warmth surveys are actually available for free on our website to anybody.
Ooh.
So if you go to the resources tab and you look for warmth surveys, you'll actually be able to download them for 3 different kinds of stakeholders. So there's no money exchanged in that. They're available as a tool. So I'm really glad you brought that up. And I hope you don't mind me popping that in.
No, I'm grateful to know that. Thank you, Laura. That's wonderful information. So the warmth survey is available on the Eden Alternative website. That's great. Thanks. If you want to know, and you do want to know, how your staff are doing, I think we need to keep in mind that not only do individuals who work in your organization come with their own events that have happened in their lives, but doing the work we do can be traumatizing. And there are differences and distinctions between compassion fatigue, vicarious traumatization, secondary traumatization, burnout, and there is something called compassion satisfaction as well. In doing some research, I discovered that there is one instrument that will distinguish these different kinds of potential trauma and get a measure for professional quality of life, and that's the ProQOL tool. There's a website for that. The link is in your packet. I've also given you that tool. There's a version that is self-scoring, and that's the version that I've provided in your packet. There's a wonderful website that goes along with this tool. It is an evidence-based tool. I think it's important to know how people are doing that are working for you and start talking about this stuff so that it becomes a normal thing to talk about the events that happen in our lives, not just for the people that are living in our nursing homes or receiving services, accepting services from us, but also working together. This is what takes stigma away and makes it possible for people to start to feel better about the things that have happened and start to celebrate the ways that we all are survivors and that we can support one another in helping and doing better. So I just want to let you know that's available as well. So when it does come to resident assessment, I want to say that there are evidence-based tools, but I want to build in a little caution about using them. And the reason is there is still a lot of stigma about trauma. There is stigma about mental health issues. If someone lives with depression, there is stigma about that label. And I work with folks in my therapy practice who have stigma about things that maybe not everybody would even feel stigma about. I have worked with people who feel stigma about having been divorced or who feel stigma because their parents were divorced. I have worked with people who feel stigma if they, I'll give an example. I live in Ithaca, New York, where Cornell University is located and where we have a lot of people who have doctorates in lots of different subjects. And it's a community where if you don't have a doctorate or at least a master's degree, you might feel intimidated. And I work with a lot of elders who've moved here from somewhere else who frankly feel intimidated if they don't feel like their educational credentials are the same as their neighbors. And we don't know what might be the trigger for someone to feel less than. So I think we can't just sort of blithely hand somebody an assessment form or start asking questions about negative events and not expect that some of those questions themselves might not be triggering. So I think that concept of being well known is so critical here, especially when we're working with elders, people who may have come from a generation where certain subjects were not talked about as freely as they are today. Um, Premarital sex was probably happening but wasn't talked about. Pregnancies before marriage were happening, but they were not talked about the way they are now. Cultures do differ in what is acceptable to talk about and who talks about it. We have to be culturally sensitive. We have to be sensitive to cohort effects as well. Cohorts being people of a certain generation may have different things that are acceptable to talk about and are not acceptable to talk about. We just need, again, to get away from ageism or culturism. We need to know the individual. That's the key. And that takes time. And so I would say we want to do trauma screening, but we want to do it in a way that is sensitive to the person. And that means not doing it the very second that someone comes into our service. I've included the questionnaires and checklists that are evidence-based. You need to know them. You need to have them in your toolkit. But I want to say weave them in and have your teams talking about, excuse me, when and where and who is the right person to ask these questions. I want to share some questions that I learned about in doing my research that I think are really sensitive to the moment. This is referred to by the developer as the briefest screen ever. And if you're just meeting somebody, it would be appropriate to say, do you feel safe speaking to me today? And if not, what might help you feel safer? We hear this question a lot in primary care settings, or I worked in an emergency room, and we had to, by law, ask people, do you feel safe at home today? This gets at whether there might be abuse at home today. And if not, how can we help you feel safer? And here's a question that starts to get at past trauma. Did you feel safe at home as a child? And if not, and we're not asking for details, how might that affect you today? And these were developed by Gabriella Grant. In your handout, I've given you a link to her PowerPoint presentation on how to work with elders who may be living with trauma. And I think it's worth going to that link and just going through her PowerPoint presentation. She works for the California Center for Excellence for Trauma-Informed Care, and I think she has a good presentation on this topic. So this might be a good first step, and then save some of those other questions and checklists for after you know someone a little bit better and you've developed a relationship. Relationship is the glue. So again, I've given you links to these evidence-based screening tools. Just a reminder in your handout that you have them, and you had them in last week's handout. You had a chance to work with them personally. Here's one that we use as clinicians. It's a short form to get at whether somebody may be living with actual post-traumatic stress disorder, which is the clinical name for a traumatic stress that actually reaches a point where it's creating significant problems in someone's life. And I just wanted to include it again as an evidence-based tool for your toolkit. These are some things that I want you to keep in mind as you're moving forward and starting to implement trauma-informed care in your organizations. First of all, early screening and comprehensive assessment are important, but again, within that context of being well known and developing relationships and making sure people feel safe to speak with you before you even start asking these questions. Care and services need to be person-directed, and that means being driven by the consumer. The workforce itself has to be educated about trauma. and what it means to be trauma informed and to be trauma responsive. Best practices are always being developed now. It's a very exciting time because we can do things with understanding how the brain and the body respond to trauma and how we heal from trauma. So it is an exciting time to pay attention to emerging best practices. Environments have to be safe and they have to be secure. And our partnerships can be developed around this whole idea of trauma-informed care. We can develop relationships with providers in the community, with other organizations, and this is one of the best ways that we can continue to grow in this area. And you want to develop a monitoring system that will help you stay on top of this performance, and whether that's involving your MDS nurse in your organization, if you're a nursing home, your quality person in your assisted living or your home care agency, whoever that person is that you decide is going to help you track your performance measures, you want to make sure they're on board as well. In the Eden Alternative, we have a wonderful model to performance management, and it's called the growth model. It's a great way to look at growth, not just for employees, but for care plans, for residents, and for elders. It's a great way to look at projects that might be coming up for you as an organization. And this model, the growth is an acronym. It stands for getting real, for reaching out, for opening up and dreaming, for working up a plan, taking action, and then holding steady and reaching further. So it's a process. And I even have my card here. See if I can hold it in front of my. There's a whole course that the Eden Alternative offers in this. It's called Growth, 6 Steps to Implementing Change. And that first step of getting real is really about taking a look at what is really happening right now, what's happening, what's going well, what's not working so well, where are the opportunities for growth, and what are some past successes that we might be able to build on, and what change needs to happen, and why now? What's the imperative for reaching out now, or for changing now? And then the other steps have to do with reaching out. Who are the people that we're going to involve in this change? Who needs to learn about it? Opening up and dreaming is really that blue sky dreaming, getting everybody together and really sort of opening up our need to change and looking at all of the blue sky stuff that might happen. And then working up a plan, and I'm not going to go too deeply into that today with the time we have left. We're not going to do that whole process today, but I do want you to get back into your small groups. And what we're going to do is take a few moments to get real with yourself and in your small groups. And we're going to take about 5 minutes to talk about where you feel you are at with actually implementing trauma-informed care, given everything that we've talked about today, and knowing that you will be able to go and put your hands right on these instruments, these guides, and that you've got you've got a whole library basically at your fingertips. But where are you with implementing trauma-informed care? So Laura, can we perhaps go back into our groups and take 5 minutes to discuss where we are at in your own organization with implementing trauma-informed care, and then we'll come back together. Thank you. Yeah, thanks everybody for engaging in that conversation. So really, really appreciate that. And just want to see, I think we had some interesting stuff come up in the chat box too, and I want to address that if I can. One thing that came up in the chat box was a note from Hope and Rebecca, a community that received a tag due to assessing for trauma history without having the follow-up therapeutic resources for the resident. This is likely to be a big issue for organizations, especially, let me just say, I recognize the challenges there. There are a couple of system-wide problems with that. I learned not too long ago that only 3% of social workers are specializing in gerontology or geriatrics. And out in the community, I don't know how many of you are aware that I'm a social worker, for example, and I can bill Medicare. I have in New York State, I have parity in terms of the scope of my practice with PhD psychologists. Because of my level of training and my years of practice and certain years of supervision and so on, I have the practice level, although not the reimbursement level that a PhD psychologist has. But nationwide, social workers at this level of licensure cannot go into a nursing home to do therapy with clients. It's the only place we don't have parity. Um, it's a glitch in the law that several uh, congressional folks have been trying to have fixed for several years, and we just haven't been able to get that passed. It's always tacked onto some bill that hasn't been passed. If we were able to do that, it would help increase the resources. We also just need to convince more people to work in this field. So we've got some systemic issues there that are a problem. The other issue is that social workers within nursing homes are often not used in the way that they could be used. We're trained as mental health professionals outside of nursing homes. We're doing a lot of the heavy lifting in terms of mental health. We are trained as therapists, and within nursing homes, we are often not used that way. In some of your homes, perhaps you are, and I hope you are, but it's very tricky, and I can't go into all the details about that. It's the source for another full webinar. But there are ways that resources are not allocated, and there are some state and federal laws that actually stand in the way of that. And so there's an issue. Another note here is about nurse training is necessary. What about CNAs in terms of the regulations? I saw some of those regulations, and it did talk about nursing, and other places it talked about staff. So I'm not clear on that. I would say definitely reach out to your surveyors and double check that. I've looked at the actual regulation, and I'm not clear, but I think they want all staff to have to be trauma informed. I'm not sure about to what extent. So that's a really wonderful question, and I wish I had more details about that. So let me get back right now to just make sure we can wrap up and cover everything that we do want to cover today, and get to questions and answers. Make sure we can do what we want to do today. I think we covered what was in there. Just some final thoughts about things that that came up for me, and I want to hear from you as well. But I would encourage you, as you're putting together your teams and as you're exploring other questions that have come up for you, to definitely invite elders, surveyors, ombuds people, and other care partners to join you in your quest to become trauma informed and to develop programs to join you with that. To do use your social worker, your recreation and occupational therapists, any psychologists or psychiatrists that might be serving your organization, uh, other community partners, and to educate all staff, and that does include CNAs or home health aides. Everyone should be trauma informed. I think I gave a story last week, and if I think when I was talking about Sylvia and her experience, I mentioned my own experience in a diner about having a server come up and make a comment about your plate not being clean so you don't get dessert. Everybody in the organization needs to be trauma informed, because any comment that's thoughtless could be triggering for people. We want people to feel safe and welcomed, and that means people need to be trauma aware, and it doesn't take that much. You can do an in-service in an hour or 2 hours and make sure that people know and raise awareness about this topic. And I would say, as a don't panic. There are lots of resources available, and I've given you tons of them, and I've tried to steer you to the ones that are most readily available and that are free and they're good quality resources. SAMHSA is your go-to resource right off the bat. And don't feel like you have to go too far too fast. Just get your hands around these basic ones and you'll be fine. So I want you all to think your growth homework for right now is to identify 3 steps that you'll take in the next 2 weeks that you can take to implement trauma-informed care in your organization. That's your immediate task to take some steps, to identify some steps. And in your handout, you've got a worksheet where you can write those down. And I want you to do that. And right now, I want you to write them down. You've got a piece of paper in front of you. Write down 3 steps that you can take in the next 2 weeks to implement trauma-informed care in your organization. Even if one of those steps is print out my handouts and share them with my team. You've got to take action for this to work. This isn't a webinar to put away, because even if CMS isn't mandating this for your organization, this is too important to not take action on. This is best practices. It affects people more than we realize. This is about quality of life for the people that we serve, for the people that we work with, and for us in our own lives. I do want to, I'll just leave that slide up. I do want to take questions and make sure that people have an opportunity. We've got about 6 minutes according to my clock here. So what questions are coming up for people? And how do we want to do that, Laura? How can we, is the chat box the best way still?
The chat box is the way.
The way.
Please put your questions in the chat box, and maybe we could stop sharing the screen if you feel like people have it down now about the 3 steps.
Yep.
The other thing I want to point out is that we're going to need 1 minute to talk about CEUs at the end. So I'll check in with you on that, but I'll let you take it from here.
Okay. So I have my chat box up and I can see it. And please, any questions that are coming up for people, I commented on the ones that I saw earlier, but if I missed any, please give me a heads up with that. And while I'm waiting, I just also want to thank everybody for being here. It was a tremendous turnout, and I'm so pleased that there's so much interest. Specific modalities helpful in healing trauma in the elder population. Last week I mentioned a few. It does depend. So if we're talking about people that are really showing that they are having some unresolved trauma, cognitive behavioral therapy, dialectical behavioral therapy is a therapeutic modality. Anything you can do to help people feel safe, and that is about relationship, storytelling, narrative approaches. I do use EMDR, eye movement desensitization and reprocessing approaches with people. Take a look at last week's session again, and I'll give you a little more information on it in last week's session. Anything that's communal, where the person truly feels safe. Now, just popping somebody who is not feeling safe into a group event is not necessarily going to work well for people, but just developing that relationship. Narrative therapy, where people are able to tell their story in a one-on-one relationship where they've had the chance to develop some safety, is really good for people. Suggestions for employing techniques without all resources. Terry, I'm not sure I understand the question. You don't need any money to use any of the books that I've talked about. All the stuff from SAMHSA, all the handouts are free.
Terry, would you be willing to clarify your, oh, there it is.
Oh, without a strong behavioral health component. What setting are you in, Terry? Depending on where you are, what setting you're in, you might need a partnership with an organization in the community that can come in with some counseling or some behavioral health. If you're in a nursing home, for example, you might not be able to, okay, a PACE program, which is a nursing home alternative. PACE programs are set up really well to provide services right in the PACE program. I would say, see if you can find a psychologist or somebody who is a Medicare or a Medicaid provider who can actually come in, and you have an opportunity to do a really interesting model where you're actually providing some counseling right there in the PACE program. That would be really neat to look into, and I'd love to see you look into that. Get in touch with me. I'd like to hear how that might work out, and there might be some PACE programs that are actually doing that. I'm not aware of anything that would keep you from doing that. I'd be excited to hear about that. Oh man, that would be exciting. Yeah, I don't think there's anything keeping you from doing that. You guys might have some budget constraints, but if you could bill Medicare first and Medicaid second, let Medicare pay for it. Yeah. Trauma in dementia care. Ooh, I want to do another webinar on that. Again, look at last week's talk. I talked about Naomi Files' approach and Al Power's approach to experiential care. I absolutely believe that people who live with dementia have unresolved trauma like the rest of us do, and anything we can do to lower their stress and increase their ability to express themselves gives them a chance to talk about their past in a way that allows them to resolve past trauma and to have healing. So I think people who live with dementia or other cognitive challenges have a right to talk about those issues and to have other things offered to them as well for healing. So I think it can be done. We need to keep talking about that and experimenting with it.
Lisa, I'm going to go ahead and jump in now and say I'm really glad we were able to get some questions, which clearly spoke to some different people. I can see some comments about that was a great question. But I would like to go ahead and close the webinar and say thank you to you, Lisa, for, wow, like 2 sessions of just rich information, a lot of different pieces of the puzzle that are really important. And thank you for being so comprehensive. I always appreciate and love your work, and I'm so happy we've had the opportunity to feature what you do.
Oh, thank you. Thanks for having me here.
Oh, easy, easy. And so with that, it's time to share the CEU information. And so I'm going to put that up on the screen and tell you exactly what you need to do to accomplish what you want to accomplish with your CEUs. Lisa, will you nod at me and let me know that this information is indeed up on the screen? Yay. All right. This is what you're going to do. So make sure you're taking notes. We want you to send an email to sgerold, SGEROULD @edenalt.org. You must send this email before March 19th. That's exactly 2 weeks from today. Okay. The subject line should say CEUs for Trauma-Informed Care Session 2. And the statement in the body of the email should say, I promise I was there start to finish. And make sure that you send this again by March 19th. This is the most important part of all. There's a code phrase that only you know because you stayed till the end. And it is empathy changes lives. So make sure that you include that in the body of your email. Send this to Sue Gerold at our home office by March 19th, and then you'll be able to get an electronic certificate of completion and then pursue your CEUs. Once again, thank you all for being here. Thank you so much for being willing to jump into breakout rooms with complete strangers and have conversations that I hope were meaningful for you. And have a great afternoon and evening.
Thanks, everybody.